Good afternoon. I want to thank everyone for joining us here this afternoon to discuss a critical issue of ensuring equity in coronavirus vaccinations. The coronavirus pandemic has hurt all Americans, but some communities have shouldered an especially heavy burden. Black, Hispanic, and Native Americans have been infected with the coronavirus at higher rates than white Americans. They are nearly 4 times as likely to be hospitalized and twice as likely to die from the virus. Many members of these communities are frontline workers who continue to face serious health risks in the workplace. And it's not only about race. Other vulnerable communities, including lower income and rural communities, have faced disproportionate hardships during this crisis as well, and especially in recent months. I am grateful that millions of Americans are now receiving coronavirus vaccines, but the evidence is clear that our most vulnerable communities are at risk of being left behind. More than 57 million doses of coronavirus vaccines have been administered so far in this country. But only 9% of those who receive vaccines are Hispanic, and only 6% are Black, even though these groups together represent nearly a third of the United States population. As we work to vaccinate all Americans, we must ensure that the communities hit hardest by the virus have equitable access to the vaccine and are being vaccinated at equitable rates. Failure to achieve vaccination equity would not only compound the suffering in these communities, but would also delay or even derail containment of the virus across the country, which could hinder a safe return to normal life for everyone. The causes of disparities in vaccinations are becoming clear. Many lower income Americans lack reliable internet access and may struggle to sign up for the vaccine appointments. Others do not own a car and may not be able to reach a vaccine site. In rural communities, residents often have to travel long distances to get access to vaccines and may not have access to pharmacies or clinics with the ultra cold storage capacity needed to store vaccine doses. Vaccine hesitancy is another obstacle. While a substantial number of Americans currently plan to get vaccinated, others have expressed concerns. In the Black community, centuries of discrimination in healthcare has resulted in mistrust that we must work to address. Let there be no doubt, the coronavirus vaccines authorized by the medical experts at the FDA are safe, and they effectively prevent people from getting sick and dying of the horrible disease. I was vaccinated as soon as the vaccine was available to me, and I urge every American to get vaccinated as soon as a vaccine is available to them. Achieving vaccination equity will take planning, coordination, and resources. This committee and many others warned of the challenge months ago, but the previous administration ignored us. Their refusal to exert national leadership resulted in chaos and confusion, with the wealthy and the well-connected far more likely to get vaccines than the poor The Biden administration has brought a fresh approach that has already shown promising results. Weekly shipments of vaccines to states are up 57% in the last month, and millions of doses are now being shipped directly to the pharmacies and community health centers. The new administration has also purchased an additional 200 million doses of approved vaccines, meaning that the country will finally have enough doses to vaccinate everyone. And the CDC is taking on vaccine hesitancy by teaming up with partners to launch an awareness campaign in Black communities. As vaccines become more widely available, we will need to accelerate our efforts to educate all communities about the safety, efficacy, and importance of receiving coronavirus vaccines. I am particularly grateful to the new administration for establishing a COVID-19 Health Equity Task Force, which will help ensure an equitable response to the pandemic. The next step is for Congress to pass the American Rescue Plan, which provides billions of dollars for a national vaccination campaign. It will allow us to hire more workers to administer vaccines, create over 1,000 mass vaccination sites, and use mobile vaccination units to reach underserved communities. These measures will go a long way to address inequity in vaccinations, but more must be done. I look forward to hearing from today's briefers about additional steps that we can take to ensure all Americans have access to a coronavirus vaccine and have confidence in the vaccine's safety and efficacy. Now, I understand the minority staff has informed us that they will not be delivering opening remarks. If that remains the case, I will now proceed to the introduction of the panelists. First, I would like to introduce Dr. Helene Gayle, who is the President and Chief Executive Officer of the Chicago Community Trust. Dr. Gayle brings a wealth of experience, having worked at the CDC for 20 years. She was a member of the Committee on Equitable Allocation of Vaccine for all the novel coronavirus and co-authored the framework for the equitable allocation of COVID-19 vaccine, which was published last fall. Next, we'll hear from Ms. Abigail Echo-Hawk, the Chief Research Officer of the Seattle Indian Health Board and the Director of the Urban Annual Health Institute. She will share the experience of American and Alaska Native communities in assessing vaccines. Ms. Echo-Hawk was also a member of the Committee on Equitable Allocation of Vaccine for the novel coronavirus and is a co-author of the group's report. Next, we hear from Mr. Frankie Miranda, who is the President and Chief Executive Officer of the Hispanic Federation, which supports Latino communities around the country and will share the experience of those communities in the access coronavirus vaccines. Finally, over the last 3 decades, my friend Latham Woodard has been a close partner in our shared effort to deliver quality healthcare for medically underserved communities. As Chief Executive Officer of the South Carolina Primary Care Association, she has distinguished herself at the national level and state as an advocate for community health centers and as someone who knows the needs of the communities we are seeking to focus on today. I want to thank Ms. Woodard for her service to South Carolina and for her willingness to share her expertise with us. We will now hear opening statements from our panelists. Dr. Gayle, you are now recognized.
Thank you very much, Chairman, and good afternoon. It is my honor to be with all of you today. And I want to thank Chairman Clyburn and his great staff and the other members of the subcommittee for the opportunity to brief you this afternoon on the importance of an equitable distribution of the COVID-19 vaccine. As mentioned, I approach this from multiple lenses. As the president and CEO of the Chicago Community Trust, where we focus on the most pressing needs of the Chicago region. And as was mentioned, I come to this role after almost 40 years of public health and global and local economic development. And as mentioned, was most recently the co-chair of the National Academy's report on the equitable allocation of the novel coronavirus vaccine. This committee was convened by NIH and CDC to develop a framework for distributing the COVID-19 vaccines. And core to this report was assuring that equity was embedded throughout our recommendations. And this report was the foundation for guidelines that have been developed since the vaccines have been authorized for emergency use. A bit about the Chicago Community Trust. For us, our highest organizational priority is closing the racial and ethnic wealth gap in the Chicago region. We believe that by closing this economic divide that is largely rooted in a history of systemic racism and segregation, the entire Chicago region will benefit and thrive. And not only will it have economic benefits, it's key to closing the education gap, the health and life expectancy gap, and so many other inequities that we face in Chicago and around the nation. We know that the COVID-19 pandemic has exposed the persistent economic and health divides between Black, Latinx, and white communities in Chicago and people of color throughout the nation, and that controlling this health crisis is essential to our economic recovery. The disproportionate rates of infection and the accompanying economic impact we're seeing in communities of color are rooted in systemic inequities and the result of decades of disinvestment and barriers to economic stability and wealth. Putting equity at the core of the vaccine rollout is not only the fair thing to do and the right thing to do, it is also the smart thing to do. The best way to control the pandemic and to set us on a course to an equitable economic recovery is to get the vaccine to where they are most needed and where the pandemic has had its greatest impact. It is sound public health policy to serve the populations most at risk, because that is where we will have the greatest impact. This pandemic has caused great devastation everywhere. Chicago is no different. We have recorded over 240,000 residents with confirmed cases of COVID-19. Of those that we have lost, 72% of the deaths were in Black and Latinx residents, who make up 60% of our population. Higher rates of underlying health conditions make the rate of serious disease more likely, but we also know that communities of color and low-wage earners are also at higher risk of acquiring the coronavirus infection because of the jobs they work, the homes they live in, the means of transportation they take to get to their jobs. As is in the case across our nation, both our city and state are working tirelessly to distribute the vaccine and control the spread of virus and minimize the impact of disease. In everything that they do, they are centering equity in their approach. So as an example, in the early stages of the vaccine rollout, 50% of people receiving their first doses were white and only 18% were either Black or Latinx. Today, 41% of first doses are among white Chicagoans, 24% Black, and 26% Latinx Chicagoans. So while this still does not reflect the population distribution of COVID-19, it shows that with targeted efforts, progress is being made. More can be done, and we all have a role to play. I'm proud that the Chicago Community Trust, with national funders like the Rockefeller Foundation, and in coordination with local initiatives like the City of Chicago's Protect Chicago Plus and the Vaccine Partnership, will support community-led solutions that not only respond to the immediate needs of our communities, but also strengthen public health infrastructure and provide jobs and career pathways for residents in heavily impacted communities. This past weekend, I had the opportunity to visit a mass vaccination site in a predominantly Latinx neighborhood in Chicago. A primary care provider was coordinated with a community-based organization and the city to remove barriers for low-wage essential workers, providing 2,000 people with their first doses in just 2 days. This morning, I attended a newly launched site in a predominantly Black neighborhood. The same sort of efforts are rolling out across the city. But besides providing greater access, we know that there remains hesitancy, as was mentioned, on the part of many to take this vaccine. In communities of color, especially Black communities, we justifiably see hesitancy about taking the vaccine due to generations of discriminatory medical practices that have caused harm and distrust. We need more than brochures, flyers, and public service announcements. We need trusted local messengers to mitigate, educate, and empower hard-to-reach and skeptical populations. We also need to assure that real-life issues like childcare and paid sick leave are addressed so that people have the ability to take the necessary time to get the vaccine and deal with any potential side effects and not have to make trade-offs between getting the vaccine and keeping their jobs. Still, we know that hesitancy is only part of this story. There are real supply and distribution challenges due in no small part to chronic underinvestment and fragmentation in our public health infrastructure. These structural barriers can be addressed with intention and with resources. That is why I'm so pleased to see legislation moving through Congress to allocate resources towards the new administration's American Rescue Plan for a national vaccine program, expanding testing, direct investment in community health centers, and a robust public health jobs program. As a community foundation that has made closing the racial and ethnic wealth gap our highest priority, we know we cannot achieve our vision for the region if we do not equitably and intentionally ensure access to COVID vaccines. It is both the prudent public health response and the responsible first step towards a just and inclusive economic recovery. I thank you.
Thank you very much, Dr. Gayle. We will now hear from Ms. Echo-Hawk. Ms. Hawk, you're now recognized.
Thank you so much, Chairman and members of the committee, for this opportunity to share with you the experiences of Indian country, American Indian, Alaska Native communities in the midst of this pandemic that is devastating our communities nationwide. I'm Abigail Echo-Hawk. I'm the Chief Research Officer at the Seattle Indian Health Board. And in that role, I direct the Urban Indian Health Institute, which is one of 12 tribal epidemiology centers across this country who is supporting our American Indian, Alaska Native communities in the midst of this pandemic. I am also American Indian. I am an enrolled citizen of the Pawnee Nation of Oklahoma. And like many tribal people, I have experienced devastating losses, not only in my family, in my tribe, and in my extended network of friends. Those of us who are working to end this in Indian country are not only doing it every single day, but we are experiencing these devastating losses like many Americans are in our everyday lives. At the Seattle Indian Health Board, which is a federally qualified health center and also an IHS-funded Indian health service provider in the city of Seattle, Seattle was the epicenter of the pandemic in February. We had some of the first confirmed cases of COVID-19. Our clinics soon became overrun by folks who were concerned about what was happening. And we had doctors who were sewing fabric masks. The executive leadership team, like myself, were washing scrubs at home, trying to get the PPE and materials needed for our staff. We put out a call because we didn't have enough PPE in our clinic in February to our state, to our county, and to our federal partners at the Indian Health Service. Before we got our PPE, instead what we got was a box of body bags. This box of body bags arrived on our doorstep at the Seattle Indian Health Board when we were expecting masks, we were expecting gowns, when we were expecting the things that we needed to provide the essential care to our American Indian, Alaska Native people, and all the other races and ethnicities who step in our door. But instead, what we received was body bags. This exemplifies and is a metaphor for what has been happening across Indian country. Due to chronic underfunding of the Indian healthcare system, the underfunding of treaty and trust obligations, American Indians and Alaska Natives have 3.5 times more likely to be infected and 1.8 times more likely to die of COVID-19. What does this mean? Well, as the co-author of those studies, I was deeply concerned when we went to do that analysis that we were only able to look at 23 states when we were looking at the infection rates, because only 23 states in this nation were reporting enough race and ethnicity data for us to do an analysis. Right now, we're not even being reported in the data, and our stories are being lost. Policymakers cannot make data-driven decisions without good data. Right now, I am a scientist who is unable to do good science. Today, my organization released a report called Data Genocide. It looked at the non-reporting of states of race and ethnicity and their reporting to the CDC across 4 factors, and it graded them on how well they were doing in representing this data, which is needed to understand this pandemic in our communities. More than half the states in the nation graded C or lower, with 13 states receiving an F. What does that mean for vaccinations? There was a recent report that came out of the CDC that showed for vaccination data, we are missing 48% of all the race and ethnicity data. And when I think about our community here at the Seattle Indian Health Board and nationwide, we know that our folks are getting vaccinated at high rates at our Indian Health Service facilities, urban and rural, but they are not getting that same care in outside facilities. In fact, one of our programs in Montana, an urban Indian program in Great Falls, Montana, was telling us that their people are being turned away at other places and being told to go to the Indian Center. The Indian Center, which receives very limited vaccines. They have vaccinated more veterans, Native veterans, than has been vaccinated by their local VAs. And they're being told that their veterans are standing in line waiting to get those vaccines at the VA. We're tired of body bags. So instead, we have taken our sovereign right to look at how we equitably distribute the vaccine. And we've seen tribes like the Cherokee Nation who vaccinated their language speakers first. Seattle Indian Health Board has vaccinated 100% of our elders. The Bay Mills community in Michigan has vaccinated more than 50% of their adult population that live in their service area. And we have remote villages in Alaska who are reporting 50 to 60% vaccination rate of all village occupants. But it's done with very scarce resources. One of our clinics in Santa Clara Valley recently told me that with the rising cost of security, of sanitation, of temporary providers, they're having to take away services from other essential care in their federally qualified health center and Indian health program, and they're having to juggle every day what people are going to get. This is absolutely unfair. And as we look at what is happening right now in this nation, the focus has been how many arms can we get vaccinations into? And my answer back to them is it's all about whose arm is it? We will not end this pandemic. We will not be able to reach equity unless we are looking at those folks at the most risk for complications, hospitalizations, and mortality. Until those people are prioritized, we will not see equity, and we can't do it without the data. I'll end with a story of a friend and a tribal leader who recently passed away. As I sat on my chair with my face wet with tears, I thought, did he even get that last chance to tell his last story? Is he included in that data? Are they mark him as a white man? Our people are being lost. Our cultures are at risk. We deserve the dignity of being counted. Thank you.
And thank you very much, Ms. Echo-Hawk, for your testimony. We will now hear from Mr. Miranda. Mr. Miranda, you're now recognized.
Good afternoon, Chairman My name is Frankie Miranda. I am the president of the Hispanic Federation. And thank you for the opportunity to address you and the members of this committee. For 30 years, Hispanic Federation has centered on building power and capacity in Latino and immigrant communities and in the nonprofits that serve them. In response to the challenges presented by the coronavirus pandemic, we created the most far-reaching Latino COVID-19 relief fund in the nation, already investing $16 million, partnering with nearly 300 nonprofits in 30 states and the territory of Puerto Rico to provide care and hope to severely impacted families and communities. We recently launched our Vida initiative to provide $1 million to support 15 community health centers that serve low-income Latinos across the country struggling without adequate funding to administer COVID-19 vaccine programs. I come to you today as a leader in a community that has been devastated by COVID-19. The impact of the coronavirus on the health, financial security, and educational progress of Latino communities has been nothing short of devastating. The impact is compounded by government inadequate preparation for vaccine distribution. Latinos are disproportionately represented among so-called essential workers in occupations with lower wages, non-existing benefits, and no job security. Latinos are also overrepresented among the unemployed. Essential can also feel like disposable. Latinos account for the largest share of the nation's undocumented immigrant population, and our communities are home to millions who have spent the last 4 years in constant fear of family separation. Many will not seek essential government services for fear of having it counted against them. Inequities are now playing out in the ability to receive potential life-saving vaccinations. Available data shows a consistent pattern of Hispanic and Black people receiving smaller shares of vaccination, as it had been mentioned here before. But for example, in Texas, only 20% of vaccinations have gone to Hispanic people, who make up 40% of the population. 42% of the cases of COVID-19 and nearly half of all deaths, 47% in that state. And as of this week, the CDC reported that race ethnicity was known for only just over half, 55% of people who have received at least one dose of the vaccine. And it's been mentioned here, among the known group, nearly 2/3 were white, 9% were Hispanic, 6% were Black, and 5% Asian. Latinos make up nearly 1 in 5 of the US population, over 18%. And yet we represent nearly 33% of COVID cases nationwide. We have been dying at rates more than twice as high as the white population. We need to do better, not only for Latinos, but for the health of this country. We know from our own work and from our partners on the ground what the problems are and what needs to happen to address them. You just need to ask us. And I'm here to recommend strategies in 3 areas that will result in more equitable, targeted, and effective distribution of vaccines. First, accessibility. Barriers to access include language, lack of transportation, availability of things people take for granted, like having internet or even an email account. We need targeted programs that provide vaccination teams to go into communities where hard-to-reach populations live and work. Continuing to simply open mega sites lacks creativity and a commitment to reaching hard-to-reach populations. Number 2, and very important to me, resources to community-based organizations. We must unleash our community's greatest assets, which are our community-based organizations. And in order to do that, we must allocate significant funding to our community-based nonprofits that have the cultural competence to educate and combat the rampant misinformation, distrust, and now fraud preying on Latino communities. These organizations are our most trusted messengers with decades of experience engaging and mobilizing our communities to action, but they remain underutilized. There's also need for resources for case management personnel with the cultural competence to reach hesitant populations, persuade them to get vaccinated, help them sign up for the vaccine, and then follow up to ensure they go back for their second dose. Providing the vaccines is just not enough. And third, equity and prioritization. Federal distribution guidelines must be created to target needed and impact. There must be priority guidelines, guardrails to prevent abuse and jumping the line, and oversight, especially while shortages remain. Simply providing vaccines to people over 65 will not reach Latinos who have the highest numbers of death among younger age groups. Almost half of all COVID-related deaths in the 35 to 44 age range are Latino, at 48.9%, compared to 27.3% of Black people and 15.5% of whites. We cannot open the economy on the backs of brown, Black, and undocumented and low-income workers who continue to suffer disproportionately high rates of infection, economic hardship, and death. We need to provide equitable access to vaccine. We're not asking for equity for the sake of equity. Continuing to give low priority to Latino and immigrants is not merely unfair, it's terrible public and economic policy. This country will not recover as quickly as it needs if Latinos and immigrants continue to be treated as disposable, made invisible in policy discussions, or are left behind in the life-saving race to provide vaccines. Thank you for asking us how together we can do better for our communities, our country, and our future. We know that there is no time to waste. Our lives hang in the balance. Thank you very much.
Thank you very much, Mr. Miranda. We will now hear from Ms. Woodard. Ms. Woodard, you are now recognized.
And Chairman and other members of the subcommittee. As you heard, my name is Latham Woodard, and I am the CEO of the South Carolina Primary Healthcare Association, which I have been with the movement over 33 years. And prior to that, I was over 12 years at our state public health office, which is referred to as DHEC. In South Carolina, health centers provide primary and preventive care to over 430,000 patients throughout the state. There are over 220 sites, which serve the state's 46 counties, all of which are either rural or have rural areas in the county. Additionally, I have the honor of serving as the current chair of the board of directors of the National Association of Community Health Centers. So nationally, we have 1,400 community health center organizations spread across over 14,000 rural and urban communities, and we serve over 30 million people. Community health centers in South Carolina have stepped up to meet the needs of the communities they serve. First, we did it through testing, and now by providing vaccinations. There are at least 114 of that 220 sites I mentioned earlier that are designated and activated as COVID-19 vaccine sites. Despite these efforts, there have been challenges in deploying the vaccine to rural areas and to communities of color. Some of these challenges I'm going to mention from South Carolina, other states in our country also face. These include, just to run through, is the lack of trust, and you've heard that earlier, by some of the residents in rural areas when you have new providers coming in, mostly with mobile units, saying we're going to provide testing. Our health centers are well known in these communities and have been rooted in these communities. So there is that piece there of trust. There's also the lack of supplies. When I see a rural health clinic, and this has really happened, had 400 appointments in the category of 1A, but received no vaccine. And that was due to the lack of timely delivery, also a limited supply of vaccine. That was 400 people we had to cancel appointments for. And then there's also efforts to improve vaccine confidence. That was mentioned also, the mistrust. And whether we want to believe it or not, there are still a lot of people in rural areas and people of color that remember the Tuskegee study. And Congressman, I will tell you, I do use you as an example and say Congressman Clyburn got the shot, because they do need trusted faces to carry the right message. So combating also stories about adverse reaction. You know, it only takes somebody to get sick or have a fever or whatever. And yeah, people, that's where some of the hesitancy comes from. So you only combat that with widespread, culturally appropriate education by trusted messengers. And that's be helpful in mitigating that trust issue or that concern issue regarding how safe the vaccine is. There's also, which is not new, a lack of adequate transportation in rural areas. And recently, example is, and I know in Mississippi as well with the bad storm, I've had centers to call to say we had to cancel the clinic because the road, we can't get through. So it's not just having transportation, but having good roads as well to travel on. Additionally, and also heard this, the lack of internet access to make appointments through VAMS, which is the Vaccine Administration Management System, and the spotty connections that some of our rural areas have. Those pose a challenge. Even with internet access, we have some seniors that are just not comfortable using the internet. My 95-year-old mom is an example. And even accessing by telephone for many have proven unsuccessful. Either I've heard stories of, I didn't get an answer, or the waits are so long for an appointment. And when I go to the appointment, I have to stay 5 hours before I can get the shot. And for someone in a rural area to try to go out of their area to get the vaccination, that's not going to be a priority for them. Centers in rural areas tend to be smaller centers. Thus, when several staff must quarantine due to exposure of COVID, this limits access. Vaccine is needed, but also funding to secure needed workforce that have in some cases been furloughed, and also needed PPE and other supplies. The other challenges include how we are administering the vaccine and following the process in terms of the CDC guidelines. There has to be some flexibility in rural areas because of the timeliness of 6 hours once you break a vow. I will speed up since I have 0 time left. All the current challenges can be overcome, but I need to mention something about VAMS, and if someone asks me that question, I'll talk more about VAMS. There's some major issues in VAMS, including for us, it's not a Spanish application form, and we have a lot of Hispanic patients. At the current challenges, all the current challenges can be overcome if we work together and not in silos, in how we distribute equitably. And what I mean by equitably, not just how much dosage, but right now, not just to Moderna, waiting for Johnson and, I didn't mean to call the name, but maybe waiting for the one shot also has the optics of less efficacy for the people that you can't reach, are the hardest to reach, sends the wrong message. We must have better coordination, and that includes mobile units, which our centers use. We have been encouraged by the current administration of enhancing the utilization of community health centers. We also have as our movement, and I have to say this, we were founded under the core principles of social justice and health equity. Today, we continue fulfilling these principles as we deal with the current pandemic. Our centers are formed by the community, are governed by the community, and hire staff from within the community. We are these underserved areas. We are in these underserved areas where we are trusted providers of healthcare. Centers have been providing outreach services and using mobile units that they have refocused for COVID-19 services. And another example is we believe in partnering. There's a partnership going on right now with AARP and South Carolina Thrive to reach the 1,600 households of seniors who do not have internet access nor have the literacy ability to fill out the application. We also work with faith-based organizations. And last, in closing, community health centers stand ready to meet the needs of our patients and communities at large, and appreciate the support and confidence Congress and the administration has shown for our movement, especially with the pending $7.6 billion for funding our health centers in those other services, not vaccine, but the other services that are needed. We're very optimistic about that. So thank you again, Chairman Clyburn, and for the members of the subcommittee for the opportunity to appear before you today. And I look forward to your questions, especially about VAMS.
Thank you very much, Ms. Woodard, for your presentation and gather the answer, because I'm going to come to you for a question. We will now have members. We'll each have 5 minutes to ask questions. And I'm going to begin by coming back to you, Ms. Woodard, with my 5 minutes, and ask you not to take all my 5 minutes to talk about that one issue you've left on the table.
Okay, for VAMS real quickly, which is the system used by CDC to keep up with vaccine utilization, from two perspectives. One, from the provider perspective, when we can bulk drop the demographics of the patients we are serving, but we have to manually enter each vaccine that is done, the vaccine administration, which provides a problem when you look at the dashboard and say you've been given 2,200 vaccines, but you only use 455. That's because it takes a while to manually put that in. On the patient side, besides the Spanish speaking, the piece of emails that's required. A lot of seniors don't have email addresses. A lot of people in rural areas don't have email addresses. Let's say you have a household of 2 people and they may have an email address. You've got to create another email because you can't use that one email address for both people. So there are some issues, and not even dealing with the literacy. And one of my staff was trying to fill it out for her mother, and she got frustrated. By the way, she's a PhD, and she got frustrated filling out the form. So those are the pieces that I was talking about with VAMS. There are several others, but those two are the ones that stand out mostly for me.
Well, go ahead. I don't want to cut you short. Go ahead. You can go ahead with the next one.
The other is patients really understanding how to go and find a site. We aren't doing really good with educating, and I understand we are building this car as we are driving it. I do understand that. I understand there's limited supplies, but we have to do better with communication when it comes to how patients can access these appointments. One example is one patient called me and said that she called this hospital system to get an appointment for her mom, and the response was, well, it would be oblivion before you can get an appointment. I mean, that wasn't really the answer she wanted. Even if it was 6 or 8 weeks, that's not the right answer. The person did not know. Go to another site, not just a site in your area. You are open to go to other sites. Some don't know when they have to have appointments or not, or walk-ups. So there is still a lot of education. And even the Bureau and CDC know there are issues with VAMS and loading in sites, so they'll be designated. One of our largest health centers in Greenville couldn't get their sites designated because of technical problems.
Okay, well, thank you very much. I'm going to forego my last 2 minutes because next up for questions is Chairman Waters, and I know she's going to take more than 5 minutes. I'll yield 5 minutes or 7 minutes to Maximum Waters.
Thank you. Now that you know that I'm going to take more than 5 minutes, I understand that it's permission to do so. Okay, thank you. Thank you, Mr. Chairman, for calling this meeting. This is very, very important. And I think that our witnesses here today have basically described what the problems are and how communities of color, for the most part, are not being taken care of. And that's why We have the fact that over 12 million people in the United States were vaccinated in the first month that the coronavirus vaccines became available. Black Americans make up 13% of the United States population, but according to CDC data, they accounted for only 5% of the people who received a coronavirus vaccine in the first month. And so, Mr. Chairman, I decided to visit one of our big sites here in my district in Inglewood, California. And I had with me one of the local newspaper representatives with me in the city of Inglewood because I wanted to know whether or not this site, which is really a regional site and people can come from anywhere, whether or not the seniors were being taken care of in the city of Inglewood, where it is disproportionately minority, Blacks and Latinos. And of course, I discovered an awful lot and learned an awful lot. And so Inglewood Today, the newspaper, did put out information about my visit and it showed me, on the site, going to all of the setups on the site that people go through and what they have to do. And I've heard some of it here with our witnesses. And so what I want to ask our witnesses is this. It seems that you do understand that these systems that ask our seniors to get online and make a reservation, it's just absolutely a misunderstanding about what seniors are able to do, willing to do. They don't know what the hell you're talking about when you say get online. Some ask me, what line are you talking about? And so it is absolutely irresponsible for our seniors to have to make reservations online. And it is also cumbersome for many of these systems for them to even get online and make reservations if they know how. And many of them don't have computers either, and nobody is assisting them. The second thing is they don't have transportation. Many of them don't have transportation to these sites. And I learned at this site, if they walk on and they show up, basically they don't get taken care of. They tell them, we will send you an appointment on your email. And many of them don't even use their telephones that much. If they do, it's simply that their daughters and their sons and their grandchildren can call them. They can answer and tell them how they're doing. But when it comes to using these phones and getting emails and all of that, many of our seniors don't do that. So they are handicapped. No transportation, being told to use technology that they don't have and don't understand, can't walk on. And I hear about people who took the bus to come because they heard about a site and they were not taken care of. And then I'm learning that there are others who learn that these vaccinations are available in communities where Blacks and Latinos are, and they're not using them, and they're coming into the area and they're getting the vaccinations. And so, in addition to correcting those problems, don't you think that we should get after all of our television stations and radio stations and everything, bring on the celebrities and the sports people and talk about get your shots. I got mine. This is important to save your life. Don't you think that attending to the things that I'm alluding to and you alluded to and getting the publicity done and making the public relations efforts of our television and radio stations do more would help us in getting our seniors in particular vaccinated and would help to eliminate this disparity that we're all so concerned about. And I address this to all of our witnesses today, and we can start with our very first witness that spoke with you today, and that is Dr. Gayle.
Yeah, thank you very much for your comments, and I think it is true, and in the remarks, people did address this issue of seniors, and I think we have to realize that we've got to make systems that meet those needs. One of the sites that I visited, for instance, people could just walk on. All they had to show was that they were from that zip code, which meant that you couldn't come from outside of the neighborhood and get an appointment. So I think there are ways in which this can be handled. I think one of the things is realizing that there is no one magic bullet, and you described several things. I mean, we need to have a national campaign so that there is the same information for everybody, and people are aware of how these vaccines got created, developed, what the science is, so that we can eliminate some of the myths that are making it very difficult for people to these vaccines. And then I think we do need to work very closely with community-based organizations and build on some of the systems that are in place. So for instance, we're using in Chicago some of the census workers who were the same people who were getting to the hard to count communities and building on the work that they've done. We're using vaccine corps people are part of community-based organizations, and we're using trusted messengers so that people see people like them and believe that in fact this vaccine is safe, and that people like them that look like them are telling them that this is okay. So I think
Okay, Dr. Gayle, this is about whether or not we have a national program where people are being taken care of because we have systems that make good sense. I want you to know Mr. Clyburn and I was part of the group that met with the President of the United States. Mr. Clyburn has made it known our health clinics, our federal health clinics that we support were not even in the system. And so the President now has put on a national program with all of our health centers are going to be in it across the country, and they will all be using systems that make good sense. It's not enough to have one area of the country or one state who's saying you can walk on. And then out here in California, I'm visiting a site you can't walk on. It's one thing to say you have to have reservations done, online, and in other places you don't. You've got other ways of doing it. And so I'm very pleased that in addition to all that has been going on in places like Illinois, Chicago, et cetera, the President of the United States is going to get about $14 billion more in this rescue plan that has been announced to improve COVID-19 vaccine administration and distribution, and another $5 billion for research. So I'm very pleased that you all are here today, but we all need to preach a national program where people with good sense have made up what the process should be. And for those systems don't have Black people that are included in the decision making, they got to get them so we can tell them Black people do and what we don't do. As a matter of fact, I had to tell our people, Black people don't like to go to the drugstore to get a vaccine shot. They don't believe that. First of all, they're not happy because they've heard too much about experimentation, and some of them are reticent to get these shots. But when you tell them to go to Walgreens and some places, they say, that's not the hospital. That's not a clinic. I don't get my shots there. I have to get, so we have to straighten all this stuff out based on our culture and what we know and understand. Thank you for all the time, Mr. Coleman. I appreciate it.
I would just say in our report, I would just totally agree that a national strategy is critically important, and I'm encouraged to see that we're now taking a national approach so that there is not a scattershot approach to this, and that there's some greater systems being put in place. So thank you.
Thank you so very much.
Thank you very much, Madam Chair, and thank you, Dr. Gayle. Let me now recognize Mr. Jordan, who I think is participating by telephone. The chair now recognizes Mr. Jordan. Is he with us? It looks like Mr. Jordan is not with us. The chair now recognizes Ms. Maloney for 5 minutes.
Thank you, Mr. Chairman, for having this incredibly important hearing, and I thank all of the participants. I am very concerned that communities of color and rural communities and low-end communities are falling behind in vaccinations. In my home city of New York, predominantly Black and Latino communities have been vaccinated at lower rates than predominantly white neighborhoods. There are reasons for these disparities, but one is that New York and other states simply need more doses of the vaccine. We do not have enough doses. Mrs. Echo-Hawk I would like to start with you. Could more have been done last summer and fall to prepare for our distribution of coronavirus vaccines?
Thank you so much for that question, Congresswoman, and absolutely yes. Like I said, we received a box of body bags instead of the materials that we need, and that was evident to the resources that we are receiving. In your home state of New York, and looking at the data report that I just put out today, they are actually ranked number second to last in the reporting of race and ethnicity data. So unfortunately, when we talk about the statistics of who's getting what in returns of the vaccination,
Wow.
the you cited is terrible, but I guarantee you it is much, much worse. And in particular, as I think of the Native population in New York, you know, it has one of the largest urban Indian communities. New York City was built by Mohawk iron workers, federally recognized tribes are there, and we're lacking. We really need to see more investment. And when I think about the previous question that was asked around elders, in our Native community here in Seattle, Washington, and this happened in other places, we vaccinated 100% of our elders. How did we do that? We are their trusted home organization. We didn't rely on going online. We went to them. And in fact, for our homeless American Indians and Alaska Natives, we have providers out right now in homeless encampments, working with our homeless providers who are taking the vaccine to them. That provider can do about 15 vaccinations versus if they were in our clinic, they could do more. But it's not about doing more right now. It's about making sure we have the resources to do those who need it the most. And we're doing that with scarce resources. If we had more providers, we could be doing more in clinic and we could be reaching those most in need. And so we absolutely lack the resources. We're excited to see this investment, particularly in the qualified health centers, community health centers, because we are the home communities. And this is where the investments need to go, where the people go, where the culture is understood, and where we have their best interests and their trust.
Thank you. Dr. Gayle, let me turn to you. Based on your background as a physician and working in global health, why is it so critical to have enough doses to vaccinate everyone, not just the ones affected as rapidly as possible? Dr. Gayle.
I missed just a bit of that question, sorry.
Why is it necessary and so critical to have enough doses to vaccinate absolutely everyone?
You know, as we know, and your question inferred also, how are we thinking about this globally? You know, clearly, unless all of us are safe and all of us are fully vaccinated, then none of us is safe. And so I think it is critical that here in the United States, we really focus on making sure that people who are most at risk, who have borne the greatest brunt of this, get vaccinated quickly as possible, because that's how we are going to drive the numbers down. But I think we also have a responsibility for the rest of the world, and thinking about how do we make sure that we think beyond just our shores, because we're not safe unless the rest of the world is. So, you know, this is really about how do we make sure that everyone has access to this vaccine, but getting it to the people who are most at risk, because it's both the fair and just thing to do, but it's also how we're going to have the greatest impact on stemming the tide of this pandemic.
Thank you. Experts warned us last year that federal leadership was necessary to coordinate a massive vaccination plan. But the previous administration did not use its authority to accelerate manufacturing or create an effective distribution plan. I am grateful that the Biden administration has already made great strides in increasing the supply of the coronavirus. That includes buying an additional 200 million doses of the Pfizer and Moderna vaccines, so the country will soon have enough doses to vaccinate all adults. It also includes ramping up weekly distribution to states and sending doses directly to pharmacies and community health centers. We must do everything in our power to make sure that all Americans have access to vaccines as soon as possible. Thank you, and I yield back, Mr. Chairman. Thank you.
Thank you, Ms. Maloney. The chair now recognizes Ms. Velasquez for 5 minutes.
Thank you, Mr. Chairman, for this important hearing. And I want to thank all the witnesses for the great information that you has provided to us. Mr. Miranda, thank you for the work that you've done, not only in New York City, but across the nation with the Latino community, particularly at a time when so many in our communities, immigrant communities, Latinos and other immigrants, live in such fear for the last 4 years. So it is not only that in order to crush this virus, we need to make sure that we have access to the vaccine, but then how do we overcome, once you have access to the vaccine, the fear that so many Latinos and immigrants live under, and the lack of trust to be able to move people to get the vaccine?
Thank you, Congresswoman. I really appreciate the question. I have to admit that the last 4 years have been traumatic for our communities. The toxic narrative and targeting our communities and immigrant communities or Latinos or even those who live in the island of Puerto Rico who are American citizens that have been always talked to as in a negative way, it has an effect on the trust on government and government programs. So that is why it's so important, as Dr. Gayle has mentioned, or Abigail that had mentioned before, we need to talk about who are the messengers. And for those, right now is the community-based organizations that never stopped providing services during the pandemic. Here in New York, we know that they continue doing, while they were under-resourced and underfunded, continue to do more services, including food security, rental assistance, cash assistance, with very little, but they have earned that trust. We have mentioned in Chicago about the census workers. We can also add the navigators of the Affordable Care Act. They provide these managed assistance when people are enrolling and they have all of these issues that have been mentioned before, like the email or access to technology. So the tool is there. The third sector is ready, and the Latino community based organizations are ready. They just need the right investment to become those messengers and also becoming sites in communities.
Thank you. Dr. Gayle, how will shifting away from a pharmacy-based distribution model close the gap in COVID-19 vaccination rates in communities of color and low-income communities? You need to unmute.
Yeah, sorry. Again, I think there probably isn't a one size fits all, but as several of the speakers have mentioned, these health centers are where people go. It's where they feel they have trusted providers. And this is really all about how do we make sure that people have options and that they have options with people that they trust and places that they trust. And so the fact that there will now be distribution federally qualified health centers could have a huge impact, particularly for the communities that we're talking about, who depend on those providers for their health, who trust those providers. Those health centers are in the neighborhoods where the need is greatest. So I think that having this balanced approach, that recognizing that pharmacy and pharmacy distribution through pharmacies makes sense for some people, but not for all. And we've got to make sure that we are meeting people where they are and where they trust, and making sure that it is as convenient and accessible, and who are culturally competent and able to work with the population.
Thank you. Thank you. I yield back. Thank you, Mr. Chairman.
Thank you very much. The chair now recognizes Mr. Foster for 5 minutes.
Thank you. And am I audible and visible here?
Yes, sir.
All right.
Very visible.
All right. Well, as a scientist, I know how important data is. There's an old saying in engineering that you cannot fix what you cannot measure. And so if we're serious about ensuring equitable access to coronavirus vaccines for all Americans, then we need to have a clear picture of who has received the vaccines. Unfortunately, as our witnesses have mentioned, the data is woefully incomplete. According to a recent CDC report, the federal government has gathered race and ethnicity data for just 52% of all vaccine recipients. Only 34 states are currently reporting any vaccine data by race and ethnicity. And among those that do, the early results are alarming. The data indicate that individuals from wealthy white communities are often being vaccinated at significantly higher rates than people of color. One of the things that is impeding our access to clear usable data is the long-standing federal ban on an interoperable unique patient identifier. This is simply a patient number that's assigned to every resident of the United States. A UPI would allow every vaccination appointment, every COVID test, every COVID illness or death to be associated with a unique patient's electronic health record. This would also allow for automatic collection of race and ethnic information for patients who opt in, and would help prevent jumping the line by patients who do not qualify, and would be the greatest benefit to populations who've traditionally been underserved by healthcare. And I'm proud of that after years of effort on a bipartisan basis on the part of myself and Representative Kelly of Pennsylvania, the House last year voted unanimously to remove this ban. This will save thousands of lives, simplify the collection of healthcare statistics, and I am hopeful that the Senate will soon get this across the finish line. So, Dr. Gayle, I'd like to start with you. How would accurate and complete data regarding the race, ethnicity, and community of residence of individuals who've received coronavirus vaccines help us to address these disparities?
Well, as you mentioned, it's hugely important to have the data. Not having the data is like trying to fly a plane blind. You need to know where you are and where you want to go. So having the data is critically important. I think what you point to is what several people have mentioned. We are lacking core public health systems in this country. We would not have been caught as off guard if we had the kind of surveillance systems and the kind of information that you're talking about. So it is incredibly important for us to invest in this. We have a nationwide vaccination program for children that works relatively well. We don't have one for adults. We don't do a good job when flu season comes. So, there's a lot that we need to strengthen as we think about, how do we have the kind of public health infrastructure, including the data infrastructure, to be able to meet our goals and be more effective in targeting our resources. I will just add one other caveat, though. Part of people being willing to give their data is also part of this issue of trust. People will not trust and give their data if they don't feel like they get something in return. So I think part of this is also predicated on us having the kind of systems in place, services in place, so that people feel like they are being well served when they give their data as part of a health interaction. So it takes all of that. But your point is very well taken. We need to invest in a public health infrastructure. Having the data and surveillance systems is a key part of that.
Yeah, no, I agree completely. I think every one of us has had the experience of going into some new clinic or hospital and then filling out all of these forms with the exact same information that is already there on 10 different computers somewhere, but you simply can't say, here is my patient ID, and just have all that data collected.
It's inefficient, it costs us, and in the end, we don't get the job done well.
Yeah, I know that after we succeeded in passing the repeal of that ban in the House, we got a letter of appreciation from 53 medical societies who just really don't want to spend as much of their life as they do with duplicitous forms. Now, I'd like to talk a little about VAMs. Late last year, the Trump administration hired a private company to develop this software called the Vaccine Administration Management System, or VAMS, for vaccine sign-ups, inventory, clinic management, and so on. And the early reports, confirmed by our witnesses, is that it's been very difficult to use, often stalling out and malfunctioning. This seems to be really a repeat of what we've seen from the Trump administration's repeated behavior of first mismanaging the COVID crisis and then trying to compensate with some emergency rollout of brand new and untested software systems, instead of simply building on what systems exist. Ms. Woodward, I'd like your insight into the system. Anything more you can say about your experience with VAMs and what does it do and what should it do to better serve your community's needs?
And
Direct
CDC.
that at someone.
Am I muted? What did you say, Congressman?
What,
Yeah,
Yeah.
we can hear you. We can hear you now.
Okay. One of the things I want to recognize is that both HRSA and CDC and our state public health department know it's a problem and saying they're going to fix it. But in the meantime, it's not fixed and it's discouraging patients. It's discouraging our providers. We are having provider burnout because of the administrative hassle of trying to individually enter each patient vaccination. The flip side of that, are the results of that, is we are now getting less in supplies, in vaccine supplies, because all you have is the data to look at. You scientists know how that is. You know, we got to have data, but we need to have accurate data. So one center I looked at was they had 2,200 doses. In VAM said they only had 455 vaccinations they gave, so they didn't get the next amount of doses they need. So there is a problem of uploading. There's also a problem of information being dropped. Our state wanted to use another system and CDC said, no, you know, we've used this for the flu. And all we know is that it is overloaded and everyone recognized you got to change something, but change is not going to happen immediately.
Yeah,
And so you
that's
do
very.
have people also not getting appointments and actually giving up and just saying, you know, I'm not going to do this. I tried to fill it out and I gave up.
Yep. Yeah, I know. Yeah, Zeke Emanuel, the mayor's brother, describes, who's a doctor. He describes how, and he studied other countries. The way it works in other countries is you show up, you say, here's my card. Here's my card. And they say, okay, according to that, look at your age, you know, where you live, everything about you. And this is your priority on the list. And then here's when you qualify for a vaccination, and based on where you live, boom, it sets up an appointment for you. Okay. And the key of that is to get the universal patient identifier so that people can associate themselves with their medical record.
Yes, sir.
Anyway, so well, thank you very much for staying in the fight here, and yield back.
thank you very much, Mr. Foster. The chair now recognizes Mr. Raskin for 5 minutes.
Mr. Chairman, thank you for calling this very important hearing. This is a big issue in the state of Maryland. The African Americans make up 32% of our population, but are 39% of coronavirus deaths. So that's around 25% higher than would be indicated just by virtue of representation in the population. But conversely, African Americans receiving the coronavirus vaccine are 16% of the total. So that's half of what you would expect, 50% of what you would expect from African American representation in the population generally. So, and we've heard many of the reasons why communities of color and immigrant communities and rural communities and low-income communities are not able to access the vaccine at the proper rates. And I appreciate very much Dr. Gayle's points about strengthening the public health and the vaccine infrastructure generally for the underserved populations. But I'm also concerned that some people are choosing not to get vaccinated because of dangerous misinformation and propaganda about the coronavirus vaccine or vaccines in general. Many immigrant families, for example, rely on social media platforms like Facebook to stay in touch with their friends and their relatives, both here and abroad. And we know that that's where a lot of dangerous information and conspiracy theories thrive. According to the Washington Post, a recent analysis found that social media companies are far less likely to flag misleading posts or videos that are in Spanish than they are in English. And I think that the figure, if I'm recalling properly, was that 20% of dubious Spanish language posts get warnings compared to 70% of dubious English language posts. Mr. Miranda, I'm wondering whether you're seeing misinformation and disinformation spread in the communities you work with, and what are you all doing to address it? What are the countermeasures that are indicated in a situation like that? And how can the administration and Congress help to get the right information about the coronavirus out to the relevant communities?
Thank you so much, Congressman, for the question. I will go even farther. It is the same. It's a very accurate situation that is happening in our community, and I will go as far as to tell you that there is now fraudulent targets on our community, especially the Spanish language senior population has been targeted on trying to get their information and also money in order to get the chance of getting a vaccine. For us, once again, our solution to all of this is to continue investing and making the nonprofit organizations that work in community, that have the cultural, bilingual, bicultural experience, and that are inside of community, that employ people from the community, that has those health navigators used in other initiatives, or the ACA navigators, or we're talking about the census workers. All of these organizations that are right now so under-resourced and that are providing extra services to those populations, they are the best messenger, and they stand ready, and they just need better resources to actually be able to do micro and micro campaigns in their communities with their trusted Congresswoman Waters mentioned about who are those trusted spokespeople. But all of this has to be in combination, and it has to be done in community. It cannot be coming from outside or from mega sites or translations that have been done, informational materials that have been done on without the proper target on the very diverse Spanish language community coming from different countries. So absolutely.
Thank you very much. And Ms. Echo-Hawk, I'm wondering whether you would illuminate the same question from your perspective about the intertwined problems of vaccine misinformation and vaccine hesitancy in the population you serve, versus what are the effective educational efforts we can engage in?
Yeah, so the Urban Indian Health Institute, which I direct, published recently, several weeks ago, the very first national survey on perceptions, attitudes, and hesitancy on vaccine, the COVID vaccine, across the nation. So why a tiny nonprofit? Because nobody else had done it. And unfortunately, I had to do that with a small amount of funds, and it didn't reach as far as I would like, but it gives us a snapshot. Right now, all of these vaccine campaigns are being conducted on a national level without our voices and without the investment in those who can reach into the Native communities, into Hispanic, Latinx communities, African American communities who know best. So we did it. And what we found is that Native people are afraid. They're afraid they don't trust the CDC, the NIH, as a result of things that happened in the previous administration that eroded the public trust in these public health institutions and research institutions. They're afraid they're getting tested on like we have been done in the past. However, hesitancy and willingness to get vaccinated are not mutually exclusive. So we actually found that Native communities were more likely to get vaccinated in our study as compared to the rest of the country. 75% of them were willing to get vaccinated if they received more information. And so we used our study, we created materials, the first of its kind in the country, using the science, using the data, the limited data that we had, including trusted messengers. Representative Deb Haaland was the #1 messenger people wanted to see get vaccinated. Representation matters. It's why we're all so excited about her nomination to the Department of Interior. Those things matter, and so we're using that information. Without it, so prior to our survey, after it was launched, I received inquiries from federal agencies to contractors who received federal money. They wanted my data because they had been given the contracts to do these public health campaigns, and they didn't have the information. So instead, they wanted to take what little I had, take the economic investment coming from Congress, and use it for their benefit versus investing in our communities. So those resources need to flow to us, and it's our voices that have to be shaping these interventions.
Thank you. I yield back, Mr.
Thank you very much, Mr. Raskin. The chair now recognizes for 5 minutes Mr. Krishnamurthy.
Thank you, Mr. Chair. Can you hear me?
Yes.
Okay, well, thank you so much. Dr. Gayle, I'd like to ask you a question. And as a representative of the Chicago area, I'm so pleased that you are joining us. And we're honored that you're here. Thank you for your work over the decades in the early stages of the AIDS crisis and in eliciting a presidential apology to the Tuskegee Airmen. And I understand that your own father was a Tuskegee Airman and a physician. So thank you to your family for your incredible public service. And let me direct a question to you as a physician about a phenomenon that we're noticing, which is hesitancy among healthcare workers to taking the vaccine. In one hospital in the suburbs, 40% of healthcare workers were hesitant to take the vaccine. And I would just be curious about any observations that you have about whether you have noticed similar patterns or greater patterns among even physicians of color.
Thank you very much, and thank you for representing our state well. Just to set the record straight, that's my husband's father, who was a Tuskegee Airman. But anyway, I don't want to claim something. But anyway, I guess yes. We are seeing that trend, across the country, that healthcare workers themselves have hesitancy. And I think, we can't pretend that one's profession takes you away from who you are, your lived experience, your sense of trust, lack of trust. But I think the positive is that as time has gone on, we're seeing that hesitancy among health workers subside. And as more of them see their own colleagues getting the vaccine, and as more information came out, as everybody remembers, before these vaccines were authorized for emergency use, we were talking about warp speed and names that suggested, people didn't know necessarily when they created that name, but names that suggested that maybe we were taking shortcuts. And healthcare workers, of all people, being close to the science, were skeptical as well. But I also, again, a healthcare worker who is a person of color also brings with them the history of discrimination, lack of trust, and all these other issues. But I think as the information is coming out, as people are seeing more people, one of the main reasons why people say they're hesitant is that they want to wait and see. They want to see, what are the side effects? Are there ill effects? What's happening to people who look like me? So I think it is an encouraging trend to see that healthcare workers are, in fact, their rate of uptake is picking up. And that's critical, because if healthcare workers don't want to do it, it's hard to convince others.
Thank you. Dr. Woodard, let me ask you a question as well about this. I imagine that if we put Jim Clyburn on a PSA in South Carolina, everybody would start getting vaccinated. That's just my guess. But at the same time, I gotta believe that some people are hesitant about airing those PSAs right now when there's such a shortage of vaccines. In other words, they might fear that folks might say, yeah, I'm coming to get vaccinated because Congressman Clyburn told me to get vaccinated, and then they show up to your clinic or your hospital and you say, sorry, we don't have vaccines for you. How do you balance this outreach on the one hand to reduce vaccine hesitancy, and on the other hand, this terrible shortage of vaccine that you're having to deal with? Can you talk a little bit about that? I think you're muted, Dr. Woodard. There you go.
Yeah. Yes, Congressman Clyburn has influenced a lot of people, but I want to deal with the workforce, because that was one of our major problems with hesitancy. How are our patients going to take the shot if the workforce weren't going to take it? So what we did was actually Pfizer was kind enough to give us one of their scientists who knew how to speak layman's language. And our clinical staff was on a call, and you went through the process, and even this lay person felt much more comfortable, because the whole thing is you skip steps. You know, it's not safe. And when he explained, we skipped no steps. We just worked people extra hard and put in extra hours. No step was skipped. And our doctors started feeling better and started relaying that to the staff. Now, with the shortage, I think one of the things we're missing is a lack of appropriate communication. I think we need to start up front with, we know we don't have enough supply. So that's why we are prioritizing. We do expect to have enough for everybody, because we don't want to grab just the low-hanging fruit. And what that means is whomever can get there first, and they're not usually in the 1A category. So when you're very upfront statewide and who the messenger is, and that's something we at our Primary Care Association has taken on, and finding people, different cultures who are respected in the community, which is not always the doctors, sometimes it's the faith leaders, whomever it is, to explain around hesitancy and explain around supply. But we have got to just communicate in people's language and make them feel comfortable, and have a way that they can ask questions. We don't have a hotline for people to ask questions. And that's one thing I think we need. It's almost like an ombudsman of whatever your issue is, here's who you can call and get an answer.
Got it. Thank you.
And the last thing I wanted to say, I forgot to mention this. You know, we talked about a national strategy for communities, rural communities. I want to remind, we could have a national plan, but those strategies have to be culturally appropriate for that community. All rural communities are not the same. They are rural and they have some issues, but they are not the same. You've got to deal with the culture in that community and who they listen to, which is not the same in each community.
Thank you. I yield back.
Thank you very much. Let me thank all of our guests here today, the consultants who have shared their experiences with us. As many of you know, Mr. Christian Marthy mentioned earlier, the title of my memoirs is Blessed Experiences. And I said in writing that book that we are, but what our experiences allow us to be. And as we just heard from everybody here, the diversity of the communities that we serve dictate what approaches we have to make if we are going to make the connections with those communities that will make this challenge that we have successful. And we must be successful with it. And so I want to thank the presenters here today and thank all of the members for great questions that I'm sure is going to be very, very beneficial as we go forward. If the vaccinations are not administered to those at greatest risk of becoming infected, we're not going to be able to get this virus under control. And our ability to safely reopen our businesses and our schools will be threatened. The virus's continued spread among those who haven't been vaccinated also increases the risk of new vaccine-resistant variants emerging. That puts everyone at risk, including those of us who have had the vaccinations. As Martin Luther King Jr. wrote in his letter from the Birmingham City Jail, which I have quoted to this select subcommittee before, injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. whatever affects one directly affects all indirectly. The issue of vaccination equity affects us all. Access to vaccines is a critical step. We must use all available tools to make sure vaccines are distributed not just effectively and efficiently, but also equitably. I'm thankful to the Biden administration for making equitable vaccine access a top priority. As Maxine Waters said earlier, when we met with the president several weeks ago, I raised the issue of the effective distribution and called upon him to utilize the federally qualified community health centers as a way to connect with these communities, because these community health centers are trusted entities in the communities they serve. We met, I believe, on Friday morning. On Tuesday, the president announced a program to utilize the federally qualified community health centers in order to get that done. And I'm thankful for those of you who are connected to these centers, especially Ms. Latham, who I have worked with for a long time. And I want her to continue to share with this subcommittee the information that they're gathering out there. You are the national president of your association, and I want you, as you gather information from all of your members as to what their experiences are, and please get that to this subcommittee so that we can share with this administration exactly what your experiences are out there, so we can be more efficient and effective as we work to achieve equity. To truly tackle this issue, Congress must pass the American Rescue Act, American Rescue Plan. That plan provides the resources we need to increase distribution and get the vaccines to the communities of color, low-income communities, rural communities that have been hardest hit by the pandemic. The funds can be used and must also be used to improve the collection of data by race. I think Mr. Foster spoke to that. You get this information by ethnicity, location, to all the communities which are being underserved. I encourage all of my colleagues here to work in a bipartisan way in order to enact this critical legislation. This legislation is a must. We can argue about the size all we want to, but we cannot, or we should not, should I say, argue about size based upon emotions. What we need to do is focus on what the need is. If we address people's needs, that ought to dictate the size of this expenditure. Because if we fail to address the needs, simply because we don't feel good about the number, what will be the cost in the final analysis? That's the question that we need to be asking ourselves. And so it's essential that we provide the federal leadership to do that. And states must also play their role as well. The state should fast track the process of getting an appointment to receive the vaccine. We just heard testimony about the failure to get appointments. And I've been experiencing that. My office is getting calls all the time from people who seem not to be able to get the appointments. We must take cultural experiences into consideration when we think about what we need to do to get people appointments. So I want to thank all of us who have been working with this, and those of you who are working with this administration, I want to thank you. Let's just make sure that we do what is necessary with our colleagues across the aisle to get this rescue plan done, and hopefully within the next several weeks, so that we can get this pandemic behind us. And so thank you so much for being here today. And if no one has any other questions or comments, I am going to declare this briefing adjourned.
Thank you, Congressman, for your leadership
Thank you.
and all the members.
Thank you.
Thank you.
Thank you,
Thank
everybody.
Thank you. Yeah, Mr. Chairman, I believe you've inspired the quote of the day, which is that coronavirus anywhere is a threat to health everywhere.
Yes.
Thank you very much.
All right, bye-bye.
Bye.
Okay. Yeah, just cool. Looking at the camera.